Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for July 15th, 2026. Thank you for joining us today, and thank you to the current Osteoarthritis Action Alliance sponsors who help support our work, which includes the Lunch and Learn webinar series. Now it is my pleasure to introduce today's speaker. A doctor of osteopathic medicine, Heidi Prather is an attending physician and professor of physical medicine and rehabilitation at Hospital for Special Surgery and Weill Cornell Medicine. She also holds the title of Simonsen Family Foundation Scholar. Dr. Prather is the founder and medical director of the HSS Lifestyle Medicine Program, a standardized interprofessional program designed to help people with musculoskeletal pain improve whole person health, reduce pain, and enhance function through behavior change, which we will hear more about today. While at HSS, she has served as the clinical director for value-based programming and medical director for the HSS Osteoarthritis Pilot Program. She is also a founding senior editor for PM&R, the Journal of the American Academy of Physical Medicine and Rehabilitation. Dr. Prather's research focuses on pre-arthritic hip disorders, the hip-spine connection, gender differences in musculoskeletal disorders and athletic injuries, and the application of lifestyle medicine in musculoskeletal care. Her work has led to over 100 peer-reviewed publications, national and international presentations, and both intra and extramural funding. The title of today's presentation is Implementation and Outcomes of a Lifestyle Medicine Program for People with Musculoskeletal Conditions. Welcome, Dr. Prather.
Great. Thank you for the invitation and thanks for having me. I don't have any financial disclosures related to this topic. I'm going to walk you through where we are in our healthcare system as far as delivery methods and trying to help people get healthy and how poor job we do that. I'll talk to you about the links between metabolic health and osteoarthritis specifically, and then how lifestyle medicine is a great format in which to address this. And I'll talk to you a little bit about the outcomes of our interprofessional program and where we're going to next. So in America, we're in a metabolic crisis. About 88% of people are metabolically unhealthy, and only 12% meet all 5 criteria for metabolic health in general. 42% of US adults are obese, and that's up 30% from the year 2000. And over 37 million Americans have type 2 diabetes, and another 30 have pre-diabetes. So we are very an unhealthy nation. And that's linking to the burden we see with osteoarthritis. So 1/3 of people with osteoarthritis have 5 or more chronic lifestyle-related diseases. OA can really significantly limit a person's ability to self-manage other conditions such as diabetes and high blood pressure. A lot of it related to both immobility, but also nutrition, stress, and lack of sleep, which we'll talk about. We also know that there's a bidirectional change between a person's metabolic load and the degree of which their osteoarthritis can progress, and the risk of that progression being bilateral. So folks with type 2 diabetes are more likely to have faster progression of osteoarthritis radiographically, as well as more likely to have bilateral disease. This is costing us lots of money, $136 billion in total costs, which is around $11,000 per year per patient annually. And we know that there's about a 55% increase in all-cause mortality as a result of these reduced levels of physical activity, these chronic lifestyle-related diseases, and again, even the adverse effects of some of the medications we use, and not only to treat osteoarthritis, but also to treat metabolic health. So we don't have a cure or disease modifying for treatment right now. Our recommendations are centered around symptom control, and then if things, particularly in peripheral joints, that we have good surgical techniques where we can replace them, but we're still kind of stuck in this mode of how do we start to slow this thing down, then mitigate, and then hopefully slow progressions to joint replacement. So we know about 59% of people with OA have metabolic syndrome. And we know, again, that this metabolic disorder speeds up these changes that we see on imaging. hyperglycemia and hypertriglycerides are shown to be prevalent in folks with osteoarthritis. And again, there's an associated degradation of cartilage changes that happens more quickly over time. So maybe we should start rethinking our target for the management of osteoarthritis. And we've got early studies showing that obesity-related metabolic dysregulation is linked directly to microbiome dysbiosis, which means that imbalance of the gut microbes in your gut. And it plays a role in the progression of OA. We also know that modulating the gut dysbiosis improves metabolic function and could be an actual option to reducing progression of osteoarthritis. And this is all centered around chronic systemic inflammation. So maybe this could be this upstream potential for us to start to work on improving disease. Why does it matter? Well, it matters because there's a lot of us sick and it's costing us lots of money. But it also matters because every treatment we give for symptomatic relief that is passively given to the patient is impacted by this chronic systemic inflammation related to metabolic load. So when we try to improve somebody's movement or decrease a movement impairment, it's less or blunted by the effect of these metabolic load and systemic inflammation, as are injections and some of the medications we give, as well as patients' sensitivity to pain. So we know that metabolic load itself increases systemic inflammation and neuroinflammation, which increases or worsens pain processing. So everything we do to help people with symptomatic relief in these major buckets, these aren't all the buckets, but are actually impeded by this underlying root cause. We also know that this is a big burden in the hip arthroplasty world, and that folks who are obese, and especially those that have metabolic load with obesity, have higher perioperative complications, longer hospital stays, and lower home discharge rates. We know folks with metabolic syndrome as an independent risk factor alone, which means outside of weight, for CMS reportable complications and readmission after total joint arthroplasty. And this was one of the main reasons I was recruited to HSS. This is actually the second program I've started. The first one is at Washington University School of Medicine. It lives in the orthopedic department there. It's called the Living Well Center. They've been around for 6 years. They have $7.5 million of grant funding going through there. They've done a lot of work on COVID and mental health. I'm really looking for a return on investment because it costs money to get people healthy, and we are not incentivized as a system to help people get healthy. We're incentivized to do things to people. So finding a return on investment that is seen as worthy for a hospital system was one of my first feats at HSS, and working around this perioperative model is where we started. So I'll talk to you about that. Here's the guidelines from the ACR and AAOS, combine them together. And I outlined the things in green that are under strong recommendation or conditional recommendation are all things the patient has to self-manage, right? We tell people to lose weight, but we don't necessarily enable them. We're starting to enable them with a GLP-1, but we're still not enabling them for whole person health. And so that's where a lot of things we do in lifestyle medicine can come into play. And then the things in yellow are things that are passively given to the patient and to help with assistance with symptoms. But some of them, like an oral nonsteroidal or a duloxetine or a tramadol, actually contribute to gut biome dysbiosis. So again, that's something that can enhance the progression of osteoarthritis, as well as we know steroid injections can harm cartilage cells over time as well, especially when done repetitively. So, some of the very treatments we're doing may actually speed up the underlying metabolic source. So we need to be careful and figure out other options for that. So HSS is the hospital I work at. It's the largest orthopedic hospital in the country. It's from the 1800s. It's where the first orthopedic residents in the United States trained. It's very large. 2021, we saw 91,000 unique osteoarthritic patients. So we come up with, we're working on a virtual and integrated OA program, and we've kind of set aside these things as primary things that are important for osteoarthritis treatment, as well as adjunct treatments, all of which are, amongst the guidelines, and we've made consensus over the things that are still in that red column that haven't really been proven, and where do we stand on that when people need them. But you can see here on this graph on the left side, we're really trying to anchor lifestyle medicine in the middle of that, because theoretically 60%, around 60% of people really should see us. Usually about 20% of people are actually in an active state of behavioral change, meaning they're ready to see us and they want to make changes. So even if we whittle it down to that, we're in the tens of thousands of patients that may walk through our doors. And so we're trying to firmly position ourselves in that realm. So again, where does this all come from? How did we get here? Well, unhealthy diet, sedentary lifestyle, high stress, and medications leads to the microbiome dysbiosis, oxidative stress, and cell injury, which creates chronic systemic inflammation, which we know is related to chronic lifestyle-related diseases like obesity, type 2 diabetes, cardiovascular disease, some cancers, and depression, anxiety. So this is 2014 when I started pitching this. The first CEO I talked into doing this. And I was very tired of seeing a patient every 12 and a half minutes. And they'd say, oh, thank you so much, Dr. Prather. And I'm like, oh, what am I doing? They're going to be back in 3 to 6 months. And a lot of these people have this underlying chronic systemic inflammation as part of their musculoskeletal, and we're not marrying the two together. So if you work on your type 2 diabetes, your swollen knee, it worsens after you eat pizza with sausage and pepperoni and cheese on it the night before, are linked. And if we work on your type 2 diabetes, you may physically also feel better in your knee. Again, there are many disorders that are affected by the gut biome. We take on everything in our program, but it's pretty pervasive as a root source of why we're in the position we're in. So the change we're offering and how it's working, I'll tell you about that now. So what is lifestyle medicine? Lifestyle medicine is a medical specialty. I'm board certified in it. And it uses 6 pillars of health as first-line treatment, not after the fact, but as first-line treatment to prevent, treat, and reverse chronic disease by targeting the root of that disease, which is chronic systemic inflammation. The pillars are nutrition, exercise, substance use, healthy relationships or connections, management of stress, and sleep health. Each one of them independently has evidence based on reducing chronic systemic inflammation, and they are bidirectional with each other, which we really try to influence patient on how beneficial it can be to make a little change in how you're sleeping and a little change in decreasing your stress. You may have a big impact on how you feel. So again, traditionally, lifestyle medicine has been used for these things on the left side, treat, prevent, and reverse. And we're using it for musculoskeletal and spine conditions. And I'm working really hard to publish as fast as possible so others will adopt this and have data to take to their CEO or their president of their institution. This is what our program patient care pathway looks like. So patients can self-refer, they can be referred by other providers. We don't even require a provider to refer them. It could be the secretary talking to the patient on the phone. And then we call the patient. So we do everything so the patient is reliant. We're not relying on the patient opting in. We're enabling the patient to opt in. So we call them. They're called within 2 days of a referral being made. And then we ask them about how interested they are in making change, what our program's like, where would they think they'd like to start. And they're set up with an initial intake with myself or 2 of the nurse practitioners that are certified in lifestyle medicine in our program. And the patients choose to enroll in which program they want to be in. So primarily they're choosing the intensive program or the selective track for surgical patients. The selective plus maybe people that are working on a specific thing, such as type 2 diabetes and insulin resistance. We have a women and midlife transition program. So just we tailor it to what the patient wants. And then the patient meets with the provider, take all their anthropometric measures, all their 6 pillars of health, explain what's optional to them, and the patient creates their own program. No 2 patients program will be exactly like. Some patients may be with us 8 weeks, some people may be with us 6 months, is completely dependent on their goals. Our program is primarily virtual, which is really improved enhancement, and we are in 4 states for that reason, so we are scalable. We do a lot of digital and group-based programming because that's how we make it scalable. We have care coordinators. A care coordinator helps them schedule every single patient appointment, so they're not left to try to figure that out. You know, that's a big problem in our health system. And then we have care navigators that have a conversation with them every 3 weeks. to help make sure they get along the path. The members of our care team that they can choose from include exercise physiology, physical therapy, dietitians, weight management, smoking cessation, a health coach. We work with the Center for Plant-Based Living on culinary medicine. They've been exceptional partners. Patients can get a culinary medicine live in-person cooking demonstration once a month for free. And then we worked with our partners at Nudge Health that do our behavioral health. Again, care coordination, care navigator are part of each of these, and we progress the patient through the program. And then when they've completed the program because they're at their goal, we do an exit interview and we take all those measures again, all their metabolic labs, anthropometric, and 6 pillars of health. And now we've got a standardized program, measurable what we did, and measurable change. So this is our initial intake. Again, it has quite a few things on it. And we can get through it in about 30 minutes. The last part you'll see is where we try to figure out where they are in an active state of behavioral change, because those are the people that are most likely to really be ready for this program. What does one patient's journey look like? So this is a patient that was in our pilot program. She was 65 years old, low back pain and severe knee osteoarthritis, and she was seeking total knee replacement. So she came to us trying to get ready for that. She had a BMI of 42.8. She was pre-diabetic and vitamin D deficient and didn't know it until she was screened in our program. She reported 0 minutes of physical activity weekly because of pain and inability to weight bear, and her average pain was 7 out of 10. She enrolled and worked with the lifestyle medicine provider and went to group visits around nutrition. She went to 4 one-on-one nutrition visits with the dietitian, 1 PT visit, and 3 health coach visits. And at about 10 weeks, she had lost 10% of her body weight. Her hemoglobin A1C and vitamin D had normalized. She went from 0 to 100 minutes of physical activity, and her pain reduced from a 7 to 2 on average. And that's before her knee replacement. That's out without injections, and that's without other medications. This is what we've been doing recently. These are kind of my numbers through March of this year. So we're getting over 1,200, around 1,100 referrals a year now. We have operative and non-operative. Obviously, it's the hospital for special surgery, and the first target is to help surgical patients get healthier. And so 88% of those that have a surgical date hit that date on time when they enter our program. And then we were sent patients that the surgeon had said, like, you're too unhealthy. It's too risky. I won't do surgery on you. And 57% of those were able to convert to have surgery just in 2025, which represented 82 incremental surgeries for our hospital. And there's my return on investment. So I feel like we're very solidly here, and I'll be working on other ways to get impact, both not just patients' individual care in other subgroups of types of patients, but so that everyone can have access to this and we can find a financial way to make that solid. So in our program, this is a sample of 1,800 patients. You can see that 87% of them have 2 or more chronic lifestyle-related diseases. These are some of our basic baseline measures when we take, and you can see the average person is somewhat impaired from anxiety and depression. 75% or more have a sleep impairment. Our cumulative minutes of physical activity are averaging around 80, but around 50% of people involved actually report 0 physical activity minutes. And most of that is because they're unable to weight bear or have a pain problem. We've published on this. We're the first to publish on a lifestyle medicine program used for surgical optimization. And it's of any surgery. These were primarily hips and knee arthroplasty. There's some backs, there's a foot, and there's a couple shoulders. So 74% reported weight loss. The average numeric pain score went down by 3 points. 61% have an improvement in hemoglobin A1C. When they did, the mean reduction was 0.5, so it was quite large. C-reactive proteins go down, lipids improve, and we work hard on making sure we can get vitamin D normalized. When patients choose to work with a one-on-one with a counselor and our Nudge Health partners, we see dramatic improvements. Depression, anxiety, insomnia improves by 45% and a decrease in pain of 47%. Can't recommend this company enough. They've been excellent, excellent partners in crime in this mission. Our highlights of our research from 2025 is that we looked at people who were interested in the program and active change and compared them to people who were not interested in being in our program in both groups, same surgeons, same hospitals, same diagnosis, same risks. all the same, compared those two groups for their hip and knee arthroplasty at their 90-day outcomes. And what we found was those who completed the program were more likely to have a reduction in infection, which represents healthcare savings in a bundled payment model for post-surgical patients, and less persistent pain, which we find to be a very big deal, not only costs, medications, and suffering by the patient, but it's also thought to be one of the biggest problems for total knee arthroplasty right now in our country is why are people having persistent pain when their knee arthroplasty looks phenomenal? And we lowered it by quite a bit there. We found that people that were using GLP-1s did not get those effects, regardless if they were in our program or not. And so we're now working on consensus around how to support those people better, particularly bone health, muscle mass, and reduction of inflammation. So again, here's our consensus of where we're moving forward with our HSS OA program, and we're really hoping to have lifestyle medicine as being a center focus of that for patients who are interested. This is my team. We're rapidly growing. I am very grateful to this group of people who have taken this crazy idea from a physiatrist who's just tired of the way we deliver healthcare and have really helped me with implementing this. It's been a very fun journey, and it's a very satisfying way to practice. This is our QR code. I'll take any questions you might have.
Thank you, Dr. Prather. That was great and so much wonderful information in there. We do have time for some questions, so anyone in the audience can feel free to type a question into the chat and I will read it aloud. Dr. Prather, we did have one come on kind of when you were doing some background that I didn't want to interrupt you, so I'll ask it now. Could you explain a little bit more what metabolic malfunction is?
So metabolic, I think I called it burden. So there's metabolic syndrome, which is the combination of any three of high blood pressure, high cholesterol, type 2 diabetes, and obesity, particularly around the middle, your abdominal obesity. And any three of those combinations is considered metabolic syndrome. But anybody with has a metabolic disease has some level of burden of metabolic dysfunction because that disease is created by the chronic systemic inflammation that's underlying it. And so I spend quite a bit of time at the beginning explaining that we're not just going after symptom control. I think there's great potential if we start this early enough for folks, and this becomes widespread education, we might have some mitigation of the progression of OA in people who like to work in this fashion of adopting a healthy lifestyle. You might say, well, most people don't want to do that. Certainly the hospital I work at said that. And they were hoping that this program would, probably see around what they identified was their high-risk folks, around 221 patients a year. And like I said, I had over 1,100 referrals. When I was first asked, who will really engage with this, I said, well, let's just follow the literature. The literature says 80% of people are not ready for behavior change and 20% are. So we'll create these tracks with the idea that only 20% of people will go into our intensive program and 88% will decline, and we'll give them information and start to marry these two married together, that your type 2 diabetes affects your knee OA, because they may not have heard that before, because certainly you see your diabetes doctor for your diabetes, and you see your orthopedic or your rheumatologist or your physiatrist or your sports medicine person for your knee OA, but no one's talking about how they're related. And so starting to marry those things together pushes people along the cascade of behavioral change, going from I hadn't thought about it, now I'm thinking about it, now I'm preparing to try to change, and now I'm ready for change. So it's a useful activity, but so that's what we estimated. And it actually, when our first enrollment, 72% chose the intensive program. It floored my administrators, I think, and which has been a great problem. And people really are looking for this. We just have to be able to enable them to engage. And that's kind of working against the way our system is. So, but there's great satisfaction in this. I can tell you, even if you're not doing lifestyle medicine at this group programming thing, you can charge for, and it's really, it just turns everything on a dime, because you get to spend much more time with people And the group setting really creates community for those people that are really working hard on their health. That was a long answer, sorry.
No, it's great, great explanation. And you got a little bit into, how this program can be sold to administrators and how you kind of convinced the leaders that this was a good idea for both kind of the financial perspective as well as patient outcomes. So we have a couple more questions in the chat
You have to be
here.
persistent. You have
Yeah,
to be persistent. Don't give up. That's my answer. That's my comment there.
great. Um, what
Yeah, go
about
ahead.
what about folks without metabolic syndrome who do have osteoarthritis? What are
Nope.
some appropriate referrals for them?
So people always ask me that question, what's the right referral? And it's like anyone who's interested in how do I keep myself healthy is a perfect candidate for this. And how do you know that, right? Especially when we don't have lots of time with patients or they say something in passing. So I always talk about the clues they're giving you. What supplements can I take to keep myself healthy? Boom. Have the discussion about nutrition. You can't supplement a bad diet, and we call it eating patterns. We don't like to call it really diet because we're not trying to be restrictive. We're trying to be all inclusive and eating real food. And that's the opportunity, that's a teaching moment. I take the 6 pillars on every patient I'm seeing, whether they're in the program or if they're in my physiatry practice. And you'll have some people really resistant. You can tell they're in a chronic pain cycle and it's a mess and da 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 da. And you get to the sleep part. And I don't sleep, I sleep 3 hours a night, then I'm up and I don't feel rested and pain awakens me. Okay. You can circle back, try just one of those pillars can really make a big impact on people. And there's really no one will argue with you about wanting to sleep better. People may say, I can't change my diet, I can't exercise, I can't blank, blank, blank. But I haven't yet found anybody that says I don't want to sleep better. So, diving into something that may not have as many stressors around of it can be really helpful. And when you start to explain, you don't repair your DNA at night, your pain level is high, and that's causing inflammation in your body, which then degrades the cartilage that you have in your knee or your hip or your ankle or whatever you're seeing. So that's the way I approach that.
That's great. I appreciate the comment that no one's going to argue with better sleep. That's for sure.
Yeah.
A question here. Could you tell us more? You mentioned the GLP-1 users and some outcomes you had found. Were they in use of the GLP-1 before entering the program, or was it prescribed as part of the weight management program during the
Yeah.
preoperative period?
Yeah, it's both. So some people come to us already on a GLP-1 because they're trying to find a way to get healthy. So you got to champion those. I would say it's a little less than 20% into the program and actually want to do that. Um, you saw how unhealthy this cohort was that I showed you. And a lot of those people have been through 3 bariatric surgeries, something else botched. They took diet pills some point in their time. I mean, they've been at this a long time in their life. And it's really interesting how many of those are like, I really want to go the all natural way. I've been through the ringer with this other stuff. I think that'll change as we know how to manage those better. Our biggest concern is that, in this cohort that I saw, I don't have their metabolic labs shown there. So we're going to come back and hopefully publish that. We're still working on getting this one published. It's in review. Please cross your fingers. But did those patients tend to just let the drug do its thing and they lost the weight, but they didn't do the muscle mass? Are they eating more they're eating less ding dong on ho-hos and losing weight, but it's still not making them healthy. It's not a part of health. So we have to make sure people are understanding what the drug does. The other thing is right now, there's really no plan to get people off these. They're expensive. They come with side effects. We'd like to show that for particularly people who've really struggled with weight, that could this be the great rocket launcher? Does the drug get you started? Can we implement change that you could adhere to? Can we slowly wean you off the drug? And because you're eating real food now, does the food noise not come back and you immediately gain weight back, which is what, the data is kind of showing now. That's all up in the air. There's so much we need to learn about these meds, and people are using them for all kinds of reasons right now. So I think just stay tuned. I think we're going to learn a lot in the next 5 years.
Dr. Prather, we're at our 30 minutes. Do you have a couple minutes? We have two more questions.
Oh,
Is that okay? Okay,
sure.
great. Thank you. So question about the physical activity pillar. Is physical activity assessment part of the EHR pathway? Do you use PAVs or do you use something else? And follow up to that, what do you think about referring outside of your existing clinical structure to programs, community programs like arthritis appropriate evidence-based interventions?
Yes, great. Great question. So our physical activity intake right now is patient reported. Um, and we go through all the different types of physical activity, aerobic, strength, flexibility, whatever they're doing. And we add up those cumulative minutes for now. We add up vigorous, non-vigorous, we're all about just move. And then I have been working for 2 years, and we get to start it in September with the University of Washington has created a way for a wearable to be downloaded into Epic. A provider that they're signed up with to receive that data can run a report of all their patients that are on the wearables. And then AI creates a message back to the patient from the provider about, like, great job. I saw you did X last week. Think about Y next week. Or I saw you had a down week. Or, yeah. And then if you start to see trends that it stays down, it may trigger a phone call, like, what's going on? That kind of thing. So the back and forth of that, I think, is going to be really exciting. The University of Washington has this in 8 different departments there, and they've done only steps. And we're like, a lot of our patients don't have steps because of a pain problem. And so they've adapted it for regular, just man, monitoring movement and as well as sleep. So I'm really excited that we'll have measurable data that right now we're using patient reported, and we'll be able to look at those trends, and it's not perfect. It's off a wearable. We know that's not perfect, but it gets us closer to the patient being able to take on self-management issues. The question about community, absolutely. When somebody graduates this program, they need still support. So we have a maintenance program where they can always come back to HSS for one webinar a month and free culinary medicine for life. That keeps brand going. That's why my hospital likes it. You got the brand going and people trust us. But that community integration is so important. So we're working on a network of whether it's providers or community programs, or where people can get physical activity access that's not so costly, which in the city of New York can be difficult. But I cannot, and that's a wonderful question. I'm glad you asked it, because that is key, because that's how they're going to sustain over time, is that constant reinforcement. And when you're in collaboration with people in your community, you're more likely to adhere.
Great. Thank you. I'm going to squeeze in one more question here. I'm going to kind of combine two. What is the coverage, the insurance coverage for any of this program? And as far as access, if people in the audience were interested, do they have access even if they're not in New York? What's the access like financially and
Yes.
geographically?
Yeah. Great question. So it's a hybrid model. So dietitians, despite the fact that 2/3 of our country is pre-diabetic or diabetic, and 2/3 of our country is obese or overweight, as you know, many people don't have access to a dietitian. It's crazy. So the hospital has given us a great cash price. So if patients have zero access and really need one-on-one care with the dietitian, they can be seen for an eval at 120, and their return visits are at 70, for which for New York is it's greater than 50% off what the actual cash price would be. So I'm grateful to the hospital for that. What we do is workarounds. I'm just going to give the example of the dietitian is group programming. So say a Medicare patient that has no access, and they don't have diabetes, or they don't have chronic renal disease, they don't have any access to a one-on-one dietitian. So we create these group programmings. We call it Ask the RD, Ask the Registered Dietitian. I will get on and do a check-in with each patient independently. I write an independent note, and then the dietitian takes off with the content for that day, and then the dietitian and I stay on together for the question and answer session. And that's where patients can get really direct access one-on-one to the dietitian in a setting that's paid for by their insurance. We're not entirely losing money on it. In fact, we make money if we have 5 or more patients on it. A little, not a lot, but making the finance people happy. Um, and it's a win-win. So we have group programming at night, during the day. I do one Saturday in a month, and we do all 6 pillars of health. We do book club. We just did book club last Saturday. We have behavior change. We have setting goals. This is the most fun and creative thing I've done in medicine. And people say, hey, I want more of X. We have several just on explain pain and how it's related to what you're doing with their lifestyle change. They love it. And I can see anywhere from 20 to 30 people on at once. I'm affecting 20 to 30 people at a time. It's wonderful. You don't need a referral to see us. This is our QR code. You can go on our website. Our phone number is there, and you just need to be in a state where we're all licensed. So that's New York, New Jersey, Connecticut, and Pennsylvania right now.
That's great. Thank you. We hope other states in the future.
Yeah, well, they keep asking me, are you scalable? I'm like, dang it, I'm in 4 states. Well, it's New York. That's not good enough. So
Everybody
if we
wants
want to
you.
go, let's go.
That's great.
So we'll see. We'll see. Thanks again for inviting me on this. And you're just such a prime group to get this information too. And I really appreciate your interest.
Well, we are
Have a great
thrilled to have you. Thank you so much for your time today, and thank you for sticking around a little bit longer to answer some questions. And thank you to everyone who attended today's presentation. Just launched a brief satisfaction poll if people can take that before they leave. And also just wanted to remind people about our next Lunch and Learn, which will be on September 16th at 12 p.m. Eastern Time. And I dropped the link to that registration. It will also be in the follow-up email that I send out later. The title of the September 16th presentation is Do Patients and Physicians Agree on Rheumatic Disease Diagnoses? A Comparison by Disease Type. Thank you so much, and we will wrap it there. Have a great day.
Thank you.